Hi everybody, this is Dr. Dean Harrison from Chiropractic BioPhysics Seminars and Technique and Chiropractic BioPhysics Nonprofit Research, a spinal research foundation. We're going to do our 27th video review of one of Chiropractic BioPhysics Techniques research publications this week. So we have 26 others. For those of you that are just tuning in and seeing these, remember, what we're doing is going through each one of our research publications in a video format. This is not cherry picking a research presentation here and there. This is covering each one of our publications individually on a weekly or bi-weekly basis. Sometimes I don't get to it every week, but most of the time it's weekly basis. So we have many to go through. You can see this list, it's almost completely updated. There's 147 papers on there, and we're on our 27th. So please, if you will look at the previous 26, you can pick the ones you might be more interested in based on their title and the type of research project it is, but check out the other ones too. What I did last week for video number 26, I went through a case study to change things up again. This week, I'm also going to go through one of our published case reports. Case studies are really nice. There's a challenge. Let me just put it out there. There's a challenge. The research community, the insurance company, the government agency, what they see as a case report, they see a nice coincidental story. The story may or may not be true, right? The story may not be meaningful. However, the clinician, the doctor that was providing care to the patient and the patient themselves, they know what they experienced. They know how their life and their health has been impacted. The case report is very dear to the patient and the clinician. Also realize this, the case report is a type of evidence. It is a type of evidence-based healthcare. It is a publication. It is a real entity for that clinician and for that patient. The other thing is the practicing clinician, the doctor that's in private practice, everybody that walks through their door is an individual. They are the case. They are the case report. A patient does not want to be treated as a mass randomized trial. The patient wants to be treated as an individual. So without further ado, along that line, let's describe the individual response of this case treated by a clinician in private practice. This case was published in 2007, Journal of Vertebral Subluxation Research. My good friend, Dr. Paul Oakley out of Canada, Dr. Bob Berry, Robert Berry out of New York, Montour Falls, New York, and myself, Dr. Dean Harrison. Now this is really the case from Dr. Bob Berry. Dr. Bob Berry is the clinician, is the intervening practitioner in this particular case. A structural approach to post-surgical laminectomy, a case report. In other words, we're going to see that this person failed traditional surgical intervention for a pretty complex low back disorder. Then he saw a chiropractor, Dr. Robert Berry, and we're going to walk through the treatment and the results. We have a 35-year-old male with a chronic history of low back and leg pain following a work injury. He was treated conservatively at first with pain medication and management. That failed. Then what he did was he went to the surgeon, and the surgeon did a laminectomy. A laminectomy is where they remove parts of the back of the vertebra so they can decompress or open up the neural elements as they run through the lower lumbar spine. So you take a posterior approach, you open the person up, you cut off the lamina of the vertebra. So you'll see that there's a shadow on the x-ray we're going to show where you can see missing pieces. Okay? It's called a laminectomy at 2 levels, L4 and L5. This surgery was a failure. The patient still had chronic low back pain and leg pain of a bad intensity, 8 out of 10. 10 is severe, bedridden, incapacitated. This patient is an 8 out of 10. The patient is on narcotic medication, Vicodin. He takes it twice a day. Oswestry Disability Index. His Oswestry disability is off the chart, 74%. That means he's severely disabled. He cannot do things. He cannot work. He cannot pick up his children. He cannot go for a walk. He is severely disabled, severely disabled. He's got reduction of his range of motion. He can only bend forward by 15 degrees. That's a really bad issue. He can't bend down to get things. He can't squat very easily, right? So you get his challenges. He can't even perform backwards bending of the spine called extension, right? He has very limited flexion. He can't even do extension. Muscle strength testing. His leg muscles are really weak. We've identified the left leg flexors as being the weakest, 4 out of 5. The left Achilles reflex. The Achilles is the tendon that goes from the calf muscle of your leg down to the heel. The Achilles reflex could not be elicited. He doesn't have a true reflex response. What that means is there's likely still compression of the nerve or neural elements that go down to the lower leg. So we don't get a reflex response when we hit that with the little tapper that doctors will do on the tendon, and you get a contraction. We don't see that. And then the L5 dermatome, that means the skin revealed lack of sensation where the L5 nerve root goes. So he doesn't have proper sensation in his leg. Orthopedic tests. Now these are just tests that doctors do. I'm going to skip over these. What these identify is there a disc injury? Is there compression? Is there tension on the nervous system, adhesions, etc.? These are outcomes that matter to the doctor. They guide and direct us. They also show some limitations to the patients. The patient's limitations, though, are better shown on the previous screen or the previous slide. So here's the patient. We blocked out his face so you can't recognize him. The most pressing issue that we see is an altered postural presentation. Now this is his neutral upright stance. He's standing relaxed. Lo and behold, what do we see? The largest thing we see is a rib cage shift or translation towards his left side. You can see there's more space between the arm and the ribs and the arm and the hip on this side. You can see a slightly high left shoulder. This is called a trunk translation. Now in previous videos I've gone through this posture and shown you the biomechanical response of the spine to this posture. We've published, we've investigated that and studied that in subjects. This guy has a large trunk translation. When you translate over, this puts pressure on the discs in the low back. This puts pressure on the muscles. They have to contract to support this. This can put pressure or traction, the neural elements, by the way. So we can have stretch and pull and pressure placed on the nervous system. This could be an explanation for why he's continuing to suffer. His x-rays, we're going to focus on the ones that showed the most abnormal configuration. Here, this one is his lateral cervical. The lateral cervical, I did not show you his posture from the side, but we have a significant forward head translation. It's almost 2 inches, 47 millimeters. From this point on C2, cervical vertebra number 2, to back here, relative to what we call cervical 7, that distance tells me how far his head is forward. The upper neck is shifted forward in front of the lower neck. He's got forward head posture. It looks like this from the side. 2 inches. Now, here's his jaw. So you can see he's looking to your reading left. The reality of it is, this can also put pressure on the low back. What I'd like everybody to do, if you're watching this video, participate with something with me. Take your thumbs, put them in your mid-low back muscles. Poke them in on each side in your mid-low back muscles. Feel the tension in your low back. Now keep your head relatively neutral and poke in there and feel the tension. Now stick your head forward with your thumbs still in the back muscles, and you will notice a dramatic rise in the muscle tension and activity. Your low back muscles have to react in response to the head going forward. We know that this is true. We've done research on this as well. I'll likely go through that project at a different time. But your head being forward, the top floor of your body, if it goes forward, your low back has to contract. So what we're seeing on this x-ray, this is one of the possible scenarios that is giving rise to some of his low back condition. Okay? Also, what we see from the front is we see his low back x-ray, Instead of being purely vertical, straight up and down, we see that he is translated or shifted off to one side. That translation is 16 millimeters. 16 millimeters is roughly 25 to 30% of the maximum range of motion. So his body is stuck at 25 to 30% translated off to one side. Now you can see the surgery that was done right here at L4, L5. See this shadow? There's bone missing here. If you go to the vertebra above, you don't see that. This is the spinous process. This is the lamina. Well, those have been removed here at L4 and L5 to decompress, in theory, the nerves and the nerve roots there. Many times when people have a disc herniation or bone spur, it's putting direct pressure on the nerves. Removing the back part of the vertebra can take away some of that compression load. In this case, it appears that it hasn't really solved the problem. So he's got missing bone. There's nothing that you can do about that now. Those bones are missing. Okay, so here's his rib cage translation relative to his x-ray. You can see both of them are shifting to the reading right, which is his left. So what do? Well, we're going to do postural adjusting. In CBP, we do mirror image or opposite postural adjusting. His rib cage is shifted to the left. We're going to shift it to the right and do chiropractic adjusting techniques for the spine. We're trying to change that abnormal position, changing the load on the spine and the connective tissue and the nerves. We're also going to work on that forward head posture. Okay, so we're going to do adjustments. We're going to do exercises for this, and we're also going to do traction, opposite traction for this. So let's see what happens. Or let's see what they look like, excuse me. So here's one technique for the mirror image or opposite postural adjusting. The patient is prone or on his stomach. He was shifted to the left, so we're going to shift the rib cage to the right. So if you look carefully at this photo, the hips and legs are dragged over to the left, the rib cage is shifting to the right, and what we will do is we will apply pressure to certain parts of the spine and do our chiropractic adjusting, either in the low back or the mid back, or in some cases the cervical spine. We can then also do this sideline. We're going to lie on the left side. By lying on the left side over a block, it translates or shifts the rib cage to the right relative to the pelvis. So in this case, you can see the model is shifting the rib cage to the right relative to the plane of the pelvis. So these are opposite postural adjusting techniques. These are done every day the patient comes in. Minimum is 3 times a week. Better to have it done daily, right? The more you do something, the better the results are going to be. These are other adjusting techniques. There was a mild twist in the pelvis. Okay, very hard to see in the postural photos that I showed you from the front. We need to look at somebody from the back, and you can see that their pelvis is rotated either one side forward and the other side back. In this case, what we're doing is we're rotating the pelvis relative to the feet and legs, trying to push the pelvis forward on the left side, meaning it was rotated posterior or backwards on that left side. So this is Dr. Robert Berry doing the adjustment for the patient. And then here he is doing another adjustment for that rib cage translation. So he shifts him to the right, and then he lays him back, and he does a chiropractic adjustment. This is the patient doing the exercise. Hey, look, it's not rocket science, but you need to be coached on this. If your posture is translated or shifted to one side, you must translate it and shift it to the other side. So we teach patients how to do active, coordinated, controlled movements that move the body into its opposite postural pattern, or its mirror image that we call it in CBP technique. So this guy, he was shifted to the left, so we're teaching him to do translations of the rib cage to the right. So if you look, we've got a block here on the right hip. The legs are kept even with the pelvis. The feet are approximately femur width apart. And then we teach him to shift straight over with the rib cage. If you go too far, you're going to bend. So just slide. Just slide over, don't tip. We're going to do this at least 50 repetitions a day. We start at one set of 10 repetitions and we work the patient up to 50 repetitions, okay? And it's not a rapid ballistic movement, it's a controlled movement. It takes a couple seconds to get into the posture, and you should hold it for 2 to 5 seconds and then slowly release. That's how you do it. This is the Berry Translation Traction Table. Now the cool thing is, Dr. Robert Berry up in New York, he is a clinician, but he also is kind of an innovator. Dr. Bob has seen things in his career that he didn't have the right tools to correct the patient case for. And so what he did is he developed this translation traction table. It's called the Berry Translation Table because Dr. Berry designed this. What it'll do is it'll take your rib cage and slide it each way. You can also take the head and neck and slide them also. In this case, we're working on the thoracic translation in the table, so just the thoracic piece. You'll notice the rib cage is being translated to the patient's right. Okay? This is called the Berry Translation Table. It helps us slide the posture over, hold it there, so the muscles and ligaments can stretch into their new posture. We start people at 1 minute per session, and we work them up to approximately 5 to 10 minutes in this type of traction. This type of traction, we typically stop it at 10 minutes for most cases. You can go longer, but most people do quite well at about 10 minutes maximum each visit. Start slow, work your way up. It's a stretch. 36 visits later after doing this, approximately 10 to 12 weeks, here's the outcome. The translation went from 16 millimeters down to 1 millimeter. The chief complaint was an 8 out of 10 severe. It's now a 2 out of 10. That's a huge change. We've got a case that had 6 months of chronic pain intensity following surgery. Now we've done corrective chiropractic with CBP methods, Dr. Bob Berry, and we've reduced this trunk translation. Now he's a 2 out of 10. 8 to a 2. Is that a significant change? I think so. You call it coincidence. The clinician calls it, it's absolutely related to what the patient and the doctor were doing. You might call it a nice story. You might say, oh, no evidence. However, the patient and the doctor know what the patient's experience was. This individual has achieved a response, and it is a result of what was being done. There was nothing else new, right? So it's related to the care. That's what the doctor, the clinician, and the patient would say. Okay? You make up your own mind. Do you want to look at a case and go, it's coincidence? Or do you want to go, wow, that's cool. This guy's life has been changed by this corrective chiropractic intervention. I don't know which one you are. You pick. Are you the glass is half empty, or are you the glass is half full? Do you want to walk around going, life sucks? Or do you want to go, hey, it's a great day to be alive? I don't know which one you are. Revised oswestry, 74%. That's severe disability, down to a 40%. Now you might go, well, that's not a big change. Yes, it is. That's a huge change on the oswestry. If you change the oswestry by 4 to 6 percentage points, that's a big deal. This case has changed 34 points. He's gone from severe disability down to approximately mild or moderate disability. Is he still disabled? Yes. Does it mean there's more care that should be done? Yes. Let's find out as we go. Now his range of motion, remember, he could only bend forward 15 degrees. Now he can bend over to 70 degrees. He can now bend over and pick things up. He can now lift his child carefully, which is a huge deal. He's got young children, young kids. Can you imagine as a parent? Let me connect with you here for a minute. If you're a parent out there, you know what this means. If you're not a parent and you don't have an emotional sense or feeling in your entire body and soul, you don't know what this means to somebody, right? If I can't bend over and pick my child up, what does that mean to me and my child? That's a huge deal. Now somebody can bend over and pick up their child. That is a huge deal. As a parent, I get to connect with my child. I don't have to look at this child and go, oh, I'm sorry, I can't pick you up. I've got a back problem, right? Put this in perspective. The patient couldn't do extension or backwards bending. Now the patient can extend with some pain, but at least we can do the movement, right? The Achilles reflex was absent. No reflex there. Now it's a 1 out of 2, meaning there's a little bit of a response. There was no response before. Now there's a response, meaning, hey, there's a little bit better nerve activity, a little bit better nerve function. There's some messages getting through, right? The dermatome testing revealed improved sensation to the left leg in the L5 nerve root dermatome. Okay, this is a big deal. This means, hey, the nerve is working better. I can feel better. I can move better. This is what's going on. Here's the before and after x-ray. It's not just an x-ray. This is the guy. This is what he started with. This is what he now has. Is this related to the overall case? Yes, it is. Did he look like this before? Yes. The x-ray showed it. Does he look like this after 36 visits? Yes. What was the difference? The intervention. It caused this. It's not an accident. It's not he's just standing better. No, this is how he now stands. This is now him. Okay? You're looking at his spine. His spine is now really vertically aligned. This is good. You still see the surgical hole, right? Obviously where the bone was removed. So now his low back looks pretty good from a structural alignment point of view. What do you do now? We'll talk about it. Here's what happened. Because his posture was corrected, now we don't need to do this lateral sideways translation correction. Let's change tactics. Okay, now let's do this. Let's focus on his neck, because his neck still needs work. His head's forward. And let's work on strengthening and stabilizing his low back. Let's do some extension training of the extensor muscles. See, here's the thing. In CBP technique, oftentimes people come in and they hurt so bad they can't do certain exercises. The guy's shifted way over like this. He can't even bend backwards. Are his low back muscles deconditioned? Yes, they are. After surgery, you can bet that they are deconditioned. Absolutely. He can't do activity, so his muscles are starting to waste away. Will there be fat infiltration to the erector spinae muscles in the thoracolumbar fascia? Yes. The problem is, at first, he can't do exercise, so we have to work to correct his spine. Then we start doing exercise. Here's what was done. Now we're going to have him do modified extensions to start with. So here's a modified extension. It's the prone on your stomach Superman. You know, raise up, hold the contraction for as long as you can comfortably, come back down and repeat that. Do as many as you can till fatigue. Then we can get, after a while, then we can get more challenging. We can use the old Roman chair that we call it, lumbar extension exercises. Change the angle based on the patient's needs and condition. Here he is, bending forward and then coming upright and activating the low back and butt and leg muscles using body weight as the load. This is what was done. Then, let's work on his neck. Let's raise that head up in the air, posterior or backwards, and then we'll apply a chiropractic adjustment to the mid and lower cervical spine. We can also apply this to the upper thoracic spine to bring the head backwards. Additionally, in addition to the neck adjusting, let's do some traction. His head was forward. Let's pull it backwards with a traction. Now, traction is specific to the needs of the individual, their spine and their condition, and their experience. So we're going to work people into things like this. Not the first visit, but over time. So here he is on his back, creating extension of the back and rib cage, and then holding weight to pull the head backwards. We start at 1 minute, and we work our way up to at least 10 minutes in this one. Okay? So this is a type of traction to correct the neck curve and the shape in the neck and that forward head posture. Following this, 9 months later, 9 months of care, this guy was extremely disabled, severe, not a simple case. He's got neurological problems, no reflexes. He's got extreme limitation of movement in his spine. Following 9 months of care, his low back is now 0 out of 10. He's got no low back pain. It's gone. The oswestry, 74 to 40 to 24. That's a big change on the oswestry too. 40 down to 24. All orthopedic tests were now negative. The Achilles tendon reflex still reduced, 1 out of 2. Sometimes you don't get 100% improvement in the nerve activity when that nerve root has been severely damaged and compromised. It may not fully recover. The alternative is, maybe 9 months isn't long enough. Maybe 2 years later, he will show signs of continued improvement. Healing takes time. The left L5 dermatome is normal. So the sensation is normal even though the motor component, the reflex, is not. Patient no longer requires narcotic pain medication. Stop right there. That's probably one of the biggest things in this case. A patient stopping or not needing their narcotics any longer. And realize the chiropractor didn't stop the narcotic. The patient was able to stop under supervision of the medical provider that prescribed it, and now the patient no longer needs a narcotic to function. That's a huge deal. Getting off pain narcotics should be everybody's goal, when and if possible. The lateral cervical showed a change. 11 millimeters, almost half an inch. 47 down to 36. The cervical curve increased from 19 degrees to 32 degrees. The atlas plane line, the top vertebra, increased 16 degrees to 23 degrees. And then the front view translation, we followed that up to, still normal. Here's the before, after, and follow-up x-rays showing correction of the low back. 108 total visits. And realize corrective chiropractic was then moved into functional restoration training, strength, and stability for the low back. And now we've maintained proper alignment throughout this duration. And it's really dramatically improved his low back and his disability and the orthopedic neurological testing. Here's the lateral cervical. Is it perfect? No, it's not perfect, right? Sometimes it's hard to correct these things 100%. The patient needs to continue working on this. Could this contribute to some of the issues still? Yes. Remember, the head being forward can load the low back muscles. Do the analogy. That's the way it works. Okay? 48 millimeters or 47 millimeters down to 36. That's a nice change. Conclusions of this case. A post-surgical laminectomy patient that failed that surgery. 6 months later, the patient is still severely disabled, not able to go to work. Was successfully treated with CBP protocol of care, achieving a significant reduction in symptoms not obtained following surgery. Normalization of posture resulted in the elimination of these positive and orthopedic and neurological tests. 9-month follow-up revealed preservation of both posture and the patient health and disability scores. These results indicate that correction of the thoracolumbar and cervical abnormalities in alignment following surgery is achievable and may be a desirable outcome. The behind-the-scenes story. This guy, I know this because Bob continued to work with the patient. Following publication, you don't just send somebody on their way and say, don't ever come in again. The reality of it is, this guy was able to go back to work and now can provide for his family. This guy is now able to walk and do activities with the family. One of the things before he couldn't do because of his disability, he couldn't go on walks in the country through some of their property and on these nice country walks that you can do. He couldn't do that with his family, his wife, and his kids. Following this, he's now able to do that. Activities of daily living are now dramatically improved. He can now do these things, and he couldn't do them before. Process that for a minute, right? What's the biggest thing a doctor and a patient can achieve together? Normalization of their activities of daily living. That's our goal. We want you to be able to participate in your life and your work with family and friends. If you can't do that initially, and then you can do it after care, we've had an impact, right? The skeptics might say it's a case study. Well, you know what? You tell that to this patient. You tell that to his family. This has changed his life for the better. And he will tell you it's a result of what he did together with Dr. Robert Berry. That's the beauty of a case study. Is it a single case? Yes, it is. What does it mean? We don't know if these results will be achieved with everybody like this. Every case is unique. But we do know this. This case responded quite well. You never know until you try. Hopefully you've enjoyed this week's video research presentation from Chiropractic BioPhysics Nonprofit. Remember, I'm going through all of our publications, not just case reports. If you've really liked this video, please consider watching the other ones and continuing to follow us, and consider supporting us and listening to the message at the end. Until next week, thank you for your time and attention. If you like this information, if you're a patient, you need to go to a Chiropractic BioPhysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy to use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics Nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP Nonprofit will get 0.5% of all your purchases, which is a big deal. It adds.